Well, thank you. It is going to be more of a revision lecture for the youngsters because majority of you are already doing what I'm going to tell, and you must have heard some lectures pertaining to this topic, so it may be more of a revision lecture. So as we know that right atrium is the gateway to the right heart. The right heart lesions are usually characterized by a pulmonary artery hypertension and increased pulmonary vascular resistance. These lead to an increased RV overload, and this ultimately leads to RV failure and raised right ventricular end diastolic pressure. And because RA is intimately involved and bears this RV intestinal pressure, so this because of this, it undergoes a right atrial modeling remodeling, leaving an effect on the RA size and function. So that ultimately, most of the right-sided lesions have got an effect on the right atrium. So we'll discuss very briefly something about the functions of the right atrium and the right ventricle. Now, suffice to say that for any study or so, the dimensions are extremely important because they have got an effect on the overall prognosis of the disease also. So in a right atrium, remember, basically for the youngsters, a apical four-chamber view, end systole, and then because at end systole, the RA is at the maximum dimension, and these are some of the dimensions. And we also calculate the area, which is about 18 centimeters square. But now in the era of a body surface area, it is less than 9 centimeters per body surface area. Then coming to the RA pressure, this is very well known to you that the RA pressure, the direct evidences are we are talking about mainly non-invasive is an IVC diameter, whether it is increased or normal, and IVC response to respiration, whether it is more or less than 50%, and like a left-sided lesion, a tricuspid E velocity divided by E prime ratio by more than 6 or so. And based on the IVC, the general consensus of the pressures are that when both are normal, then the mean right atrial pressure is near about 3. And when one is normal and one is abnormal, the mean pressure is about 8 with the range of 5 to 10. And when both are abnormal, then it is usually more than 15 to coming to near about 20. So that this is the general sort of a guideline for remembering the mean RA pressures when depending upon the size and collapse. And sometimes when you have got a significantly increased RA pressure, then the hepatic vein have to drain against an increased pressure. So there is a systolic velocity significantly decreased and there is a predominantly diastolic velocity. Now, as you know, we don't calculate the volumes or so because it is very challenging and with very limited data. But just for the completion's sake, if one can try, they can try to calculate a right atrial volume by a 3D methods or so. And these are some of the normal values. But as I mentioned earlier, that normally we are not doing or usually on a day-to-day basis, but one can attempt or do of this a 3D of the right atrial volumes or so. Then remember when coming to the RA strain, the RA modulates RV filling by three mechanisms. One is the systolic mechanism known as a reservoir function, then the early diastolic diastasis, and the late diastolic that is a booster function. And most of the studies are usually done in the reservoir phase because at this phase the RA is exactly at the maximum dimension. And when we do a strain of the RA, it is divided into three walls: the lateral wall, the roof, and the septal wall. And then you measure from the lateral annulus and measure the endocardium. And this is what you can get values. Again, the 6 segments are divided, and you get more the values which are depicted above the baseline because it is a positive strain. And the normal values vary, but it should be more than 25%. But this is the range of the RA strain present in these cases. And these are some of the one when there is a normal individuals, you can see the RA strain is almost more than 25 or so. But the more the studies are done in those cases who have got a pulmonary hypertension, and here you see a case of a pulmonary hypertension in which there is a significant enlargement of the right atrium, and the strain is hardly about 8% or so. So most of the studies have usually been done on the cases of a pulmonary hypertension, and as a result of which the RA strain can give some indications as seen in this situation. But to be very frank, it is not done on a routine basis also because of a multiple limitations. So it is my personal view that it is more for research and conference purposes rather than any day-to-day functioning also because of a lot of technical limitations. Now, but so the summary of the RA function, whenever we give any function, we always give two-dimensional spectral Doppler, tissue Doppler, and the hepatic vein. And the time does not permit me to go into detail, but see every aspect of modality of the echo to get the RA functions. Coming to the RV functions, why is it important to evaluate RV functions is that it has got a strong prognostic factor in a number of diseases, and the prognosis is strongly related to RV function in pulmonary hypertension, and RV failure due to increased afterload is the main cause of death. Similarly, whether it is a valve surgery, whether congenital heart disease, transplantation, assist devices, you see the operative mortality is much more in those patients who have got a RV dysfunction both during surgery and follow-up, and this also holds true for cardiac transplantation, in which the RV function is very important and can go up to about 20% and anterior MI also. So that the importance of RV has come up because in a large number of diseases, it has got a prognostic significance. The problems in evaluating this are because of its location behind the sternum, peculiar shape, compromising the RV endocardium because of a large number of trabeculations. So because of this anatomical limitations, it may be they are the problems in evaluating the RV, and the inlet, outlet, and the apical portion cannot be seen in one scan plane. But the two main ones are this location behind the sternum and lot of papillary and lot of trabeculations. Now remember the basic rule in an echocardiography is imaging every plane in which that particular structure is seen. So that is a multiplanar imaging is much better rather than focusing on a single plane. So that means the RV can be seen in an RV inflow view, parasternal long axis view, short axis, apical, subcostal also. But everybody should practice what is known as a focused right ventricular view. This is an apical view in which the left ventricle is sacrificed partly, and you see the whole of the right ventricle is seen, the whole of the lateral wall is seen, and you can see a good motion of the annulus toward the apex, which form the basis of some of the RV functions. So this is one view which everybody should practice and try to evaluate. Then the RV dimensions, like any other disease, again dimensions are important also. Now it can be sometimes a rough estimate can be taken visually on the basis that the ratio of the right ventricle and LV transverse diameter at basal segments in diastole should be less than 1 or so. And when it is roughly equal to LV, it is moderately enlarged, and when it is more than LV, it is severely enlarged. So one can get a visual impression. For example, here you see a parasternal long axis view. At one glance, you can see that the right ventricle is significantly enlarged as compared to the left ventricle, and the RVH is also present. So that is the reason one can get a visual. But sometimes when the left ventricle is also enlarged, then it may give a sort of a problem. Then one should practice doing a RV focus view and can see the maximum diameter at the basal 1/3 or at the papillary muscle level. And keeping these figures in mind, at the mid RV, the abnormal figures are more than 3.5 centimeters. and basal RV more than 4.2. So again, it is worthwhile practicing for the beginners also, so that they can always get used to for two things: an RV focus view and how to measure. After a number of trial and error, you will be perfect in various measurements. So now then the coming to the basic parameters, remember, we never base our diagnosis on a single parameter, but there have to be at least 2 to 3 parameters must be utilized before we reach a diagnosis in this. So that some of the longitudinal systolic functions are TAPSE, a tissue Doppler, S velocity, global longitudinal strain, and some of the fractional area changes and other things. And we'll discuss the advanced ones subsequently. But I can tell you what is theoretical, what is practical. In many situations, we take an eyeballing. We see for the RV size, we see for the RV contractility, we see how the bases are moving, how the annulus are moving. So it can be reasonable for a daily working, and it can be a starting point that yes, there is nothing wrong in the RV functions, but it is experience dependent. So this is normally sometimes eyeballing is very important, as you will see subsequently or so. And for example, here you see this is an advanced case of a right ventricular cardiomyopathy. Now, it is evident that there is a very severely depressed RV function, and even visually, there we need not calculate various RV functions because it tells you that it is a very, very poor RV functions. So, coming to the longitudinal systolic function, the major principle of this function is that the right ventricle has got a good amount of a longitudinal muscle fibers, and these longitudinal muscle fibers cause a contraction in the longitudinal direction from the base to the apex. So like a piston, the more the movement of the base, the better is the RV function, indicating that there is a good longitudinal function. So it starts with a tricuspid annular plane systolic excursion, where we put an M mode cursor on the lateral annulus, and then when you put an M mode here, you can see the measurement from the base to the peak movement. And for example, here it is about 21 millimeter, normal is more than 17. So this indicates that the base is moving much better, and that means it is a good longitudinal function. For example, here you see a case of a right ventricular cardiomyopathy, previously known as an arrhythmogenic dysplasia, where you see a sort of a echogenic papillary, a moderator band, systolic outpouchings, atrophy, and here you see there is hardly any motion of the annulus, and here one can see that the TAPSE is about 12 millimeters, and a tissue Doppler imaging, which is also one of the tests for the longitudinal function, are also significantly decreased. So some of the key practical tips for TAPSE is that it is an indicator of a RV longitudinal function. It is a practical index of RV function. Some persons have tried to calculate a RV reaction fraction by 2 into TAPSE, and as you see here, that one of the study with the CMR RV, they found when the TAPSE was more than 22 centimeters, they predicted a RV reaction fraction of more than 40, and when it was less than 15 millimeters, it projected a less than 40%, so that there is a good relationship of TAPSE with the RVEF. Again, one can do a bedside prognostic factor by a ratio of TAPSE and a systolic pulmonary artery pressure. It can be done within few seconds, because when there is an RV dysfunction, the TAPSE becomes reduced, and usually whenever there is a pulmonary hypertension, so when this becomes less, this becomes increased, so the ratio goes on decreasing. And this has been shown by a study in which you see the normal ratio was about 0.64, and as the ratio came down, the survival rate significantly decreased. And when the value was less than 0.35, it indicated a very poor prognosis, so that it is very easy to calculate it, and then you can get the whole prognostic factor within the few minutes or so. Then the same applies for the tissue Doppler imaging, which is again a longitudinal function, and sometimes it is heart rate dependent. And when the value is less than 10 centimeters per second, it indicates an RV dysfunction. And sometimes because it is related to the heart, and if there is a tachycardia or a bradycardia, you can correct it by the formula as systolic velocity into 75 divided by heart rate gives you the heart rate corrected systolic velocity. This was we used to do many years back when we were doing a tissue Doppler by the right ventricular isovolumic contraction acceleration time, but it is now becoming a bit doubtful, but still it may be done in some centers, will not go into it also. Then then coming to the global functions, one is the RV fractional area change. Again, RV focused view, and it is the percentage change in RV area between end diastole and end systole, and the normal value is more than 35. The formula is diastole minus systole divided by diastole into 100. And but the point to note is that trabeculations and PM should be excluded into papillary muscle, should be excluded into RV cavity. So that we have seen that in most of the situations we are using a focus view, and hence this is a very important view to be taken. This was one of our cases where there was a marked RV dysfunction and the value was only about 22% or so. So the key practical tips about the fractional area change is that it is an indicator of an RV longitudinal radial function. It has got some prognostic value in pulmonary hypertension. The limitations are a technical difficulty like an imaging quality and uncertainty of the correct tracing, that whether you are tracing the endocardium or you are tracing the papillary muscles or the trabeculae. So these are the two limitations, but otherwise it can be a good indication of a longitudinal and radial function. Coming to some of the advanced, so these are some of the basic ones which we normally determine. Now some of the advanced parameters also, a myocardial strain, it is defined as a deformation of an object compared with its initial shape and is expressed as a percentage. For example, here you see, this is the length at the given point of time and this is the original length. And because there is a shortening and thickening of the length, so it gives a minus value. So this is how you calculate a strain imaging also. When there is lengthening, it is a positive value, but normally we are more interested in a negative value. And so it is a measure of the percentage of a systolic shortening of RV free wall from base to apex compared to diastole. And we measure either an RV free wall or an RV global longitudinal strain. RV free wall is more informative because septum is not included in it, and the average value according to the ASC guidelines are minus 25% or so. So remember that this is the normal value, and it can be done if need be also. For example, here you see the right ventricle, and this is the graph how we get out the various segments, and this is, and you see a very markedly reduced global longitudinal strain with a value of only minus 7% or so, as indicated. This was a patient of an advanced pulmonary hypertension. Again, when you see a various tracings, this is the average peak strain, and where it is overall markedly decreased. So that the key points about the longitudinal strain are, it is a good index of a global and a regional systolic function. It has got a significant prognostic importance depending upon the value. It overcomes the tethering effect which is normally seen in the ventricles. It is angle independent. Some of the limitations can be that only apical four-chamber view is available, unlike the left ventricle. It is image dependent, especially when there is a lateral wall seen. And because it has got a thin right ventricular wall, which is almost 1/6 of the left ventricle, so the width of the RO region of interest is limited, because the region of interest is very important. So that is some limitation. Otherwise, it is being done frequently. Lastly, coming to the three-dimensional analysis, 3D echo holds a good promise to RV volumetric analysis, and it correlates well with CMR. How much it is done on a daily clinical practice, I am still doubtful. Although the ASC also recommends that that it should be utilized to see for an RV ejection fraction or so. And some of the latest equipment, they, besides giving the RV and diastolic and systolic and the ejection fraction, they also give us the value of the TAPSE and the fractional area change. So though it is a time consuming process, but on a daily basis, I doubt how much it is being done. And whenever you do it, again, include moderator band and trabeculation in the RV cavity, and do not trace around it also. So these are some of the examples of the RV volume and the status to of the key points that awareness is increasing. There are no geometric assumptions. It is poised to be a very good tool, well validated with MRI. Some of the limitations are that RV anatomy may not be a good friend. Image quality, especially the RVOT and the dropout will be there. In a severely dilated ventricle, whole RV cannot be imaged. And the last one is a very debatable point. Is it ready for a routine daily practice? At least we don't do it on a daily routine clinical practice. And sometimes you can use a contrast when the when the it is not clear, when the endocardium is not clear, and here you can see it is more of a dobutamine echo with a contrast allowance indicating a right coronary artery involvement in the form of an akinesia. And sometimes the same problem, this was the case of a right ventricular infarction with an akinesia of the lateral wall of this and significant RA dilatation. And this, of course, when your imaging is not very well seen, you cannot do a three-dimensional in this. So coming to the end, three views are very important, which will give you the complete RV function involvement. A four-chamber view to measure the baser RV dimension, whether you measure it or visual or tracing the RA area. This you can be by four-chamber view. A focused RV view will give you TAPSE, a tissue Doppler velocity, fractional shortening, GLS, and a 3D. And subcostal view will give you RV wall thickness and the IVC studies. So always concentrate on these three views, which will give you a full RV function involvement. And the numbers, we are happy if TAPSE is more than 17, fractional area change is more than 35, TDI, systolic wave is more than 10, MPI is more than 0.43, RV walls, free wall strain is more than minus 25, 3D RPF is more than 45, and the RV mid is less than 35 and area less than 18. So these are some of the figures which should always be kept in your echo lab, and then you can see it. So what is the optimal RV modality? What is the reality? The general consensus is, as each technique has its own limitation, a combination of approaches is still suggested for overall evaluation. And so where do we stand in day-to-day practice? A good clinical assessment. 2D echo will remain the clinical workhorse of RV evaluation. The visual impression of RV size, contractility, thickness is a starting point, and it may start or it may end here itself. Use simple and reproducible methods for routine studies like TAPSE, tissue Doppler, fractional area change, and a myocardial performance index. More sophisticated methods like strain and RVEF are promising advancements, and efforts should be made to make it as simpler and to be used in daily basis. This is a last slide, a very interesting slide in which the Binder et al. Sent a question here to about 1,200 participants from 109 countries as to which test you always prefer for doing an RV function. And what we have discussed just now, majority said eyeballing. Next said TAPSE. Then the third important came is the tissue Doppler. And the fourth came as a fractional area change. So we do these on a routine basis, and surprisingly, three-dimensional ejection fraction and a global longitudinal strain got a very minimum number of votes to be done on a routine basis or so. So that these continue to be the important methods, but they should be promoted. And this. Thank you very much.